It is the number one issue for consumers in private health. And in fact, it also impacts consumers without private health who are expressing concern that as more people drop out, it's going to put pressure on public hospital waiting lists. We need to remember that 2/3 of non-emergency surgery and over half of mental health treatments in hospital take place in the private sector. And there's really no capacity for public hospitals to suddenly take that up. For 15 years in this country, private health has been in a relatively comfortable space. It's been supported by government regulation, and people have had generally good incomes. But now we've seen since about 2010 really flat income growth in both households and superannuation income. And when the tide goes out, some jagged rocks begin to appear, and we're really seeing people begin to question some of the costs that are rising and continuing to rise in their household bills, whether it's childcare, education, energy, or private health insurance. So consumers are beginning to ask the question, can I afford this? The issue with private health is consumers have that very direct price signal in their that comes with their household bills every year in terms of the premium increase. In public health, it's disguised somewhat because the money comes out of people's taxes, and if they don't pay tax, or if they don't pay a lot of attention to the tax that they're paying, the signal is blunted somewhat. The only way that you can put downward pressure on health insurance premiums is to address input costs. There's no magic to it. And all of the rest of the discussion about the complexity of the system or how health funds are structured, whether they're for-profit or not for-profit, it's all window dressing. What goes into the premium is the input costs. And bear in mind that health funds pay out most of what they get in premium income as benefits. So 86 cents in every dollar of premium income gets paid out as benefits. That's higher than general insurance, which is 62 cents, and any other form of insurance is much lower than that again. So what we're talking about is how we can manage those input costs better. The input costs are costs of hospital accommodation. They are costs of reimbursement of allied health professionals and medical gap cover, and they're the costs of medical devices, which in Australia, unfortunately, we pay some of the highest costs for medical devices in the whole world. Look, I think for the first time in a long time, we're seeing that the government and the minister are really trying hard to solve these problems. There's no easy answer because, of course, by better controlling waste in the supply chain and managing input costs, some stakeholders are going to lose the amount of funding and value that they've received from the supply chain in the past. And that's not easy. We are talking about some powerful vested interests that need to be persuaded that the good of the whole sector, by improving participation in health insurance and improving participation in private health, that their own interests need to come second to the viability of the whole sector. And that's not an easy conversation to have.